Cardiovascular system examination introduction. In any clinical examination, a case of cardiovascular system is frequently selected. Also, it is an extremely common system tested in any oral examination. Very often, examiner asks, examine the CVS. However, many a times, examiner may ask to perform a particular part of CVS rather than the whole system and ask questions on that particular part. For example, examine the CVS, examine the precordium, auscultate here. Examiner may point a particular part if there is obvious finding. Examine the pulse. What are your findings? There may be no palpable pulse or irregular, small or high volume pulse, bradycardia, tachycardia or pulse delay, etc. Examine the pulse and auscultate the precordium. Describe your findings. There may be low volume, slow raising pulse. On auscultation, ejection systolic murmur may be present due to aortic stenosis. Palpate the precordium. What are your findings? There may be tapping, heaving, thrusting or shifting of apex with diastolic or systolic thrill. Palpable P2 left parasternal lift. What are the diseases that can be diagnosed by palpation of precordium? Auscultate the precordium. What are your findings? Present systematically, starting from the heart sounds, murmur and any extra findings. To attain a good skill, see and examine more cases. Also, make a good practice to present systematically. Remember, the examiner may interrupt at any part of your examination and ask, what is your finding? What is the likely diagnosis with this finding only? Once you are asked to examine the CVS, more likely underlying diseases are mitral stenosis, mitral regurgitation, MS with pulmonary hypertension, MS with MR, mixed mitral valve disease, aortic stenosis, aortic regurgitation, AR, AS with AR, mixed aortic valve disease, congenital heart disease, and such as atrial septal defect, ventricular septal defect, patent ductus arteriosus, Fallot's tetralogy, dextrocardia. Now, examination routine. If the examiner asks to examine CVS, then start examining systematically, including some general examination in relation to CVS. Proceed as follows. Introduce yourself. Good morning, I am doctor. I would like to examine you. Would you please allow me to do so? Tell me if I hurt you. Position the patient should be at 45 degrees with a backrest or pillows. With permission, remove the clothing to expose the chest and neck. Be careful in case of a female patient. Look at the patient carefully. Dyspneic or orthopnea may be found in left ventricular failure, cachexia in severe heart failure, face malar flush in mitral stenosis, Marfanoid face, corneal arcus and xanthelasma, which may be related to atherosclerosis in ischemic heart disease. Argyll-Robertson people found in aortic regurgitation, mouth, high arch plate in Marfan syndrome. Anemia may be responsible for anemic heart failure. Cyanosis found in tetralogy of Fallot and Eisenmenger syndrome. Edema in pitting edema is found in congestive cardiac failure. In hand examination, there may be clubbing, koilonychia, cyanosis, splinter hemorrhage, Osler's nose, red raised palpable tender nodule on pulp of finger, toes, also in thinner or hypothinner area, genuine lesion, non-tender, red, maculopapular lesion on palm or pulp of finger, xanthoma, palmar or tendon, related to atherosclerosis in ischemic heart disease, tobacco stain, found in smokers, responsible for ischemic heart disease. The pictures are showing clubbing with cyanosis, Osler's nose in finger, Osler's nose in toe. Next, examine the pulse, jugular venous pressure, blood pressure, and finally precordium. Pulse. See the following points in radial pulse: rate, rhythm, volume. Make sure you lift the arm to see collapsing pulse. Character, condition of the vessel wall, radiofemoral delay and radioradial delay or inequality. Compare other pulses simultaneously. Carotid pulse should not be seen at the same time, may cause syncope due to cerebral ischemia. Volume and character of pulse are better seen in brachial and carotid artery. Collapsing pulse in aortic regurgitation and pulsus alternans in left ventricular failure are better seen in radial. Now neck veins, that is JBP, the patient should be at 45-degree angle. Normal or engorged internal jugular vein lies medial to sternocleidomastoid. If visible, see any prominent wave. See hepatojugular reflux by pressing firmly with palm over the middle of abdomen, which raises the upper limit of JBP. Next, measure the height from sternal angle. It indicates mean right atrial pressure. Normally, it is at the level of sternal angle and invisible. Now, other signs in the neck: tall sinus pulsation oscillating up to the ear lobule, which is the prominent V wave found in tricuspid regurgitation (TR). Dancing carotid pulse, that is Corium sign found in aortic regurgitation. Vigorous arterial pulsation in neck due to coarctation of aorta. Other pulsation in neck may be present in carotid aneurysm or subclavian artery aneurysm. Now blood pressure. Measure blood pressure normal or high. If pulse is absent in one arm or there is radial or radiofemoral delay, then see blood pressure in both arms. Also in standing and lying to see postural hypotension. Low systolic, normal diastolic and narrow pulse pressure found in aortic stenosis. High systolic, low diastolic and wide pulse pressure is found in aortic regurgitation. Now precordium examination. Inspection: shape of the chest and any deformity, that is kyphosis, scoliosis, lordosis, pectus, excavatum or carinatum. Visible cardiac impulse, that is visible apex beat. Other impulses such as epigastric, suprasternal, supraclavicular or any other pulse. See mark in midline, valve replacement or coronary artery bypass grafting (CABG), thoracotomy scar, valvotomy in mitral stenosis. Pacemaker or cardioverter defibrillator box may be seen. Swelling in chest, always feel. There is some picture showing midline scar in CABG, a scar of mitral valvotomy, scar in leg for CABG. There is a pacemaker shadow. Now palpation, apex beat. Site localized in which intercostal space. Do not forget dextrocardia where it is on the right side. Distance from midline, measure with tape. Nature: normal, tapping, heaving, thrusting and diffuse. Thrill: site, apical or basal or other intercostal space. Nature: systolic or diastolic or both. Feel the carotid pulse at the same time. If the thrill coincides with carotid pulse, it is systolic. If it does not coincide, comes after or before, it is diastolic. Note: see both apical and basal thrill. Apical thrill is best seen by turning the patient to left lateral position with breath hold after expiration. Basal thrill is best seen by palm, the patient sitting and bending forward, breath hold after expiration. Also feel for carotid thrill. Left parasternal heave or lift. Place the flat of right palm in left parasternal area and feel by giving gentle sustained pressure. Presence of left parasternal heave indicates right ventricular hypertrophy. Palpable P2. If present, it indicates pulmonary hypertension. Epigastric pulsation. If present, it indicates right ventricular hypertrophy. Now percussion, usually not done, may be helpful to diagnose pericardial effusion. Area of cardiac dullness is increased and emphysema, cardiac dullness, is obliterated. Auscultation. See first and second heart sounds in all areas. Feel the carotid pulse at the same time. Yes, examiner notices. First heart sound coincides with carotid pulse. Second heart sound does not, comes after. Murmur. Site: mitral, tricuspid, aortic, pulmonary or parasternal area. Nature: is it systolic, that is pansystolic or ejection systolic, diastolic, mid diastolic or early diastolic by feeling carotid pulse at the same time. Systolic coincides with carotid pulse, diastolic does not. Radiation: pansystolic to the left axilla, ejection systolic to the neck. Relation with respiration: right-sided murmur increases on inspiration, left-sided murmur increases on expiration. Grading of murmur, that is example 2/6 or 4/6. Added sounds, if there is any pericardial rub, opening snap. Auscultate the back of chest for crepitations, that is pulmonary edema. Seek permission to palpate the liver, if that is enlarged tender liver in CCF, pulsatile liver in tricuspid regurgitation, and spleen, splenomegaly, and subacute bacterial endocarditis. Note, we should remember the following points. If mid-diastolic murmur MDM is present at mitral area, make sure that you have listened with bell of stethoscope by turning the patient in left lateral position with breath hold after expiration. Yes, examiner notices. If early diastolic murmur EDM is present, make sure that you have listened with the patient sitting and bending forward, breath hold after expiration. If pansystolic murmur is present, put your stethoscope in left axilla to see radiation. If ejection systolic murmur is present, put your stethoscope on right carotid to see radiation.